The damage to the coronary arteries you see here was not caused by atherosclerosis, but by a rare childhood vasculitis called Kawasaki disease. Because of this, the treatment approach differs from atherosclerosis in important ways.
In this video, we will discuss the appropriate management of KD by cardiologists who are experienced in the care of these patients.
Hello, I'm Dr. Jane Burns, Director of the Kawasaki Disease Research Center at the University of California, San Diego. Dr. Kawasaki published his first series of 50 children in English in 1974. Historical investigation has established that Kawasaki disease, or KD, was a new pediatric condition that appeared across Asia in the decades following World War II. KD is now the most common cause of acquired heart disease in children in the developed world, and in the US there are approximately 6,000 new cases each year. The etiology of this coronary artery vasculitis remains a mystery, but there is clearly a genetic component to susceptibility, followed by exposure to an environmental trigger. Treatment with high doses of intravenous immunoglobulin reduces the risk of coronary artery aneurysms from 25% to approximately 5%. The patients you encounter as adult cardiologists may present in one of three ways. First, they may seek your advice because of a known history of KD in childhood, with uncertainty about the state of their coronary arteries. Second, they may be unaware of their KD in childhood, but seek consultation for an unexpected high calcium score in the absence of traditional risk factors. Finally, they may present to the ED with chest pain or an acute coronary syndrome, and the large coronary artery aneurysms are first discovered on a CT angiogram or in the cath lab.
I'm Dr. Matt Budoff, professor of medicine at UCLA, and I pioneered the use of CT calcium scoring to detect silent pathology in the coronary arteries. Over the decades, this simple, low-cost, low-radiation test has become a valuable screening tool to detect the presence of calcified mural thrombus in patients with a history of KD. Only patients who developed aneurysms with their KD in childhood will have this complication, leading over time to an elevated calcium score. Shown here is the CT angiogram that was performed after this asymptomatic patient had a calcium score of 1,158 on a routine screening test. Here's the issue. This is an asymptomatic 56-year-old gentleman who exercises regularly, takes a statin for mild mixed hyperlipidemia. Focus on the distal vessels. See how healthy these vessels look. Atherosclerosis is a systemic disease. It doesn't just affect the proximal coronary arteries, it's the whole system. And that's not what you're seeing here. So when you see just proximal coronary artery aneurysms, you need to go back to the patient and interview them about a mysterious illness in childhood. Chances are they had Kawasaki disease.
In the absence of a diagnostic test, KD can be misdiagnosed as a viral infection, scarlet fever, or other rash fever illnesses in childhood. Patients are diagnosed when they present with fever and the mucocutaneous clinical signs shown here. Without treatment, 1 in 4 children will develop aneurysms in the coronary arteries. These lesions may remain silent for decades until critical stenoses or thrombosis occurs. Alternatively, low-grade ischemic demand results in the growth of collaterals that supply the territories at risk. These individuals can have asymptomatic, complete total occlusions that are adequately compensated with a robust coronary artery collateral circulation that forms during childhood. Adult cardiologists may not be familiar with this sequence of events that requires approaches in management that are different from atherosclerotic CTOs.
Hello, I'm Dr. John Gordon. I am the medical director of the Adult Kawasaki Disease Collaborative Study at UCSD and the San Diego Cardiac Center. As an interventional cardiologist, I met my first adult KD patient in the cath lab as a STEMI 30 years ago. Because of my interest in Kawasaki disease, I recognized the hallmarks of KD: large proximal coronary aneurysms with normal appearing distal vessels in a young patient with no cardiovascular risk factors. A growing population of young adults is presenting to cardiologists with unstable angina and myocardial infarction related to Kawasaki disease. Delayed recognition that the patient has KD may lead to suboptimal management of extremely calcified lesions and large thrombus burden, which may obscure the true size of the stenosis and aneurysm. This patient was treated for Kawasaki disease in childhood and had moderate coronary aneurysms. He did well until age 29 when he presented with heart failure. An attempt to stent a densely calcified stenosis was complicated by cardiac arrest. His heart failure worsened and he was referred to our group for cardiac transplantation. Here is his explanted heart with large coronary aneurysms. Cross-sections show the densely calcified left anterior descending artery that could not be dilated. This 33-year-old Laotian patient presented as a STEMI with a large thrombus burden in his giant right coronary artery aneurysm. After establishing TIMI grade 2 flow with angioplasty, he was treated with 2B3A inhibitors, heparin, and transitioned to warfarin and clopidogrel. Here is his angiogram 2 months later showing the patent large aneurysm. In the current era, we would use a DOAC instead of warfarin for systemic anticoagulation. This 38-year-old Vietnamese patient presented to our hospital as a STEMI, and the cardiologist on call placed a stent in the right coronary artery that appeared to be appropriately sized visually. The patient was discharged on dual antiplatelet therapy, but he returned weeks later with unstable angina. Intravascular ultrasound of the right coronary showed an undersized stent floating in a large aneurysm which had been filled with thrombus at the time of his acute event. Use of intravascular ultrasound on his initial presentation could have avoided placement of an undersized stent. My take-home message is this: if you see a young patient with an acute coronary syndrome, think of Kawasaki disease. Consider intravascular imaging to assess calcification and vessel size. Angioplasty and anticoagulation may be more appropriate than stenting if there is a large thrombus burden.
Hi, I'm Dr. Jiken Bhatt, and I'm an adult cardiologist at the San Diego Cardiac Center. I have had the privilege of having Dr. Gordon as my mentor over the past 5 years, and I now care for one of the largest cohorts of adult KD patients in the world. It's important for us to realize that every patient with KD has a unique story and a unique pathology. We see patients across the entire spectrum, from those who have known about their KD since childhood to those who don't get diagnosed until they have symptoms as adults. Increasingly, we see patients who learned of their condition incidentally from a stress test or CT scan. What is important for our patients and their cardiologists to understand is that unlike the typical adult patients with atherosclerotic coronary artery disease, patients with KD have lived with their lesions for decades. For those who have stenosed or occluded their aneurysms early in life, they have developed impressive and robust collateral circulation that has grown with them through adolescence and into adulthood. These asymptomatic patients can be well managed with conservative treatment and do not require revascularization with stenting or coronary bypass surgery. In symptomatic patients with ischemia, traditional approaches with percutaneous intervention or bypass surgery are appropriate. Medical management consists of a baby aspirin and statins for all of our patients. Statins provide a dual benefit. One is their traditional use to prevent coronary atherosclerosis, which can occur in our KD patients. But more importantly, statins possess anti-inflammatory properties that have been shown to provide long-term benefits. Regardless of symptoms, unlike our typical coronary artery disease patients, KD patients with persistent large aneurysms or stenoses have a high risk of thrombosis and should be placed on systemic anticoagulation as well. In the previous era, this meant warfarin with all of the associated complications and lifestyle limitations. More recently, however, we have been using apixaban plus low-dose aspirin in our patients with good results, although the long-term follow-up data are still being evaluated. With respect to monitoring and imaging, I follow our patients with stress echocardiograms on a yearly basis, or more frequently if there are ischemic concerns. As Dr. Budoff mentioned, CT coronary angiography provides valuable information on our patient's coronary anatomy. And I think an evaluation with CT angiography is important for all of our patients.
I'm the 56-year-old asymptomatic patient Dr. Budoff mentioned earlier. Honestly, it was just pure luck that I even came to his attention, through what I thought was a routine test. Apparently, a few lucky KD survivors also get diagnosed in this way. However, it's much more common they show up in the ER after a heart attack, or worse, a coroner's report. Because heart disease runs in my family, I've been on a statin for about 20 years as a preventative step. My cholesterol was fine. I only took the CT calcium score test because a buddy of mine recommended it, saying it was a great way to check under the hood. I figured my score would be in the teens, if even that. What I got back was shocking, 1158. I was incredibly lucky that someone in the first cardiologist's office I visited had been educated about KD in adults from Dr. Gordon. If not, I might have been rushed into the cath lab for some unnecessary invasive procedure, one that could have done much more harm than good. That cardiologist led me to Dr. Burns, who patiently gave me a crash course on Kawasaki disease. And after digging through my old pediatric records, we realized that a diagnosis of scarlet fever when I was 2 was actually a missed case of KD. Growing up, I was always in motion. I was a super active kid. I played sports competitively into college, and it's incredibly surreal to think I did all that with 2 giant aneurysms, even with the benefit of having collaterals. I'm sharing all this because cardiologists need to be aware that adult KD survivors are a really unique group of patients. Their care needs to reflect that.
We don't know what causes Kawasaki disease, but what we do know is that the number of adults who discovered that they suffered from KD in childhood is increasing every year. 1 out of every 1,600 adults in the US will have had Kawasaki disease by 2030. So please, spread the word.